Good morning. Welcome and thank you for joining us today for the meeting of the New York City Health and Hospital Strategic Planning Committee. Today's meeting is officially called to order. According to the bylaws, Section 14 on committee attendance, if any member of a standing or special committee of the board will not be present at a special committee meeting, the member may ask the chair of the board to request that another board member, not a member of that committee, attend the scheduled meeting and be counted as a member for purposes of quorum and voting. Therefore, Jose Pagan has authorized Molly Wassau Park, represented by Karen St. Hilaire, be counted for the purposes of quorum and voting on his behalf. So I would like to first propose a motion to adopt the minutes of the Strategic Planning Committee meeting held on November 20th, 2023. I will poll the members here for a vote. Dr. Katz?
Yes.
Sally Hernandez-Pinheiro?
Yes.
And Karen St. Hilaire?
Yes.
Great. The minutes are adopted. So next we will hear from Dr. Eric Way to provide an update on the system dashboard and related activities.
Thank you so much. Hello, everyone. So we're going to start with our intergovernmental affairs update, and filling in for Deb Brown is Laura Atlas, who will be going over the state of Federal.
Thank you. Good to meet everybody who I haven't met before. Deb sends her apologies, but she expressed that this is a very important meeting to her, and so she wanted to make sure the intergovernmental voice was still represented. So I will do my best Deb Brown impression.
Thank you. Welcome.
Thank you. In terms of the city, we're very grateful to council members and borough presidents who have been supporting us through the city budget process. We've begun to learn what they have allotted to our facilities, and we're very grateful for all of that. We don't anticipate any more pegs for this budget, which is also exciting. In terms of the state just wrapped up their session over the weekend and the very early hours of Saturday. From January until Saturday, they had passed over 800 bills, the majority of which were passed within the last week of session. So an incredibly busy finale for us. The governor now has until the end of the year to act on these bills. We're going to continue to advocate throughout the remainder of the year to make sure our priorities can at least be heard, if not fully met, which we're very excited for. A couple of highlights. We were pleased to see that there are workforce bills, which we advocated for, that were passed by both houses. This includes a bill allowing licensed creative arts therapists to bill for Medicaid, a bill allowing PAs to serve as primary care doctors for the purpose of Medicaid managed plans, making changes to the PA scope of practice and aligning supervision requirements for radiologic technologists who administer intravenous contrast media with the national standards. We'll continue to keep everybody apprised of how those bills are progressing and what the governor decides to do in terms of action. The state budget resolved earlier this spring in a generally positive place for us. The Medicaid rate was increased. There's a partial refill of managed care quality pools. Unfortunately, there's still a capital cut that remained in place, and we're continuing to work with our other partners and other hospital systems to advocate for ongoing enhancements to Medicaid. And we just want to thank everybody who came to Albany, who did lobby days with us, and who made sure that our priorities were able to be heard. And then finally, on the federal side, Congress continues to debate appropriations priorities for FY25, which will begin in October, specifically on October 1st. H&H did submit several congressionally directed spending requests, you may know them casually as earmarks, and to Senators Schumer and Gillibrand, and we continue to thank them for their consistent support for the health and hospital system.
Great. Thank you for that update. Any questions before we move on to the dashboard from members? Thank you.
Thank you.
Thank you. I'll just preface this by saying this is for fiscal year 2024 quarters 2 and 3. And overall, this is a very positive report, which we're very happy to share. So starting with our metrics that had positive trends. So under the quality and outcomes strategic pillar, our follow-up appointments kept within 30 days after behavioral health discharge went up from 63.9% to 65.4%. This is well above the target of 50%. You'll see some of these targets we've far surpassed, and for the next meeting, we're working with the executive sponsors to update those targets. this is a lot of hard work of Dr. Omar Fatal and his behavioral health team, leveraging all the staff available, including leveraging telemedicine to make some of these appointments, right when the patients are being discharged. Hemoglobin A1C control, this is under Dr. Nicola Davis and Dr. Ted Long. We keep saying like it's every quarter this is a new record for H&H, and once again, right, it went up from 69.8 to 70.1%, surpassing the target of 67.3. This is a new record for H&H. The percent left without being seen in the emergency department improved from 5.15% to 5.08%. Has not achieved the target of 4%, but this is in the setting of record volumes across all of our emergency departments. Moving on to the next page, still positive trends on the care experience. Saw a significant jump here in our inpatient care experience overall rating from 61.9% to 64.5%. This is still below the target of 66.3, but very hard to move even 1 percentage point here, jumped 2 here. MyChart activations went up from 50% to 56.2, still below the target of 60%. We are in our MyChart steering committee talking about not only how do we bring the activations back up in the post-COVID testing world, right? A lot of people signed up for MyChart just to see their COVID test results, but also how are we using utilization? How are they coming back and how are they using the tools within MyChart? So more to come on that in future meetings. The culture of safety, the total wellness encounters. Just a reminder, this is our Helping Healers Heal program. It's not just the one-on-one and group debriefs now. There's rounding, there are workshops, wellness events. The target, I think we set conservatively at 600, but it's almost 2,000. 1904 wellness encounters, up from 1,274. I know this could also look like our staff distressed and needing more H3, but we believe this is actually us expanding the program, training more peer support champions. So this is meeting unmet needs in the past, right? And doing more group debriefs, more wellness events. That's capacity related, not like our staff are more traumatized.
Yeah. Glad to hear that. So I think the target maybe needs to go up.
Yeah. Still on positive trends here. Access to care, strategic pillar, our unique primary care patients. This went up from 415,300 to 416,500. This also exceeds our target by about 10,000. NYC care, keep signing people up. 136,800, up from 126,000. This exceeds the target of 100K. And in our e-consults, 113,800 from 103, also exceeding the target. So all three of these will work with Ted to determine what's a new kind of stretch goal. Like I said, a very positive quarter. So on to our fourth slide, the positive trends here, financial sustainability. Our Metro Plus health spend, so make Sally happy, 46.6%, up from 43.3, so a nice 3% increase. And with that increase exceeds the target of 45%. Our total AR days down to 40.9 from 42.2, and that is below target, lower is better on this one, so less than 45 days.
So beating our target. Yes.
Yeah, beating
right.
the target, correct. And then this one, we are going to retire as of this meeting. Dr. Kim Mendez, our CIO, and the EITS team have completed the Enterprise Data Center migration as of December 2023. And so 100% of our overall data center initiative is complete as of this time, and it was on time. And we'll talk a little bit more about what a new IT-related financial sustainability measure to replace this one will be. So now moving on to the trends that we felt were stable. Care experience for ambulatory care, 86.8% from 86.1. It is just below that target of 87%. And under financial sustainability pillar, patient care revenue over expenses remained about the same as 73.1 from 73.8, but that is above the target of 65%. And the last one here, percent of uninsured patients enrolled in health insurance coverage or financial assistance remained the same over the last 6 months at 71. That's below the target of 90%. Now, moving on to some of the negative trending metrics here on post-acute care, all-cause hospitalization was at 2.4 per 1,000 care days. That is a slight increase from 2 per 1,000 care days. This is off from the target of 1.6. And then financial sustainability, the post-acute AR days is 48, so a slight increase from 45. Still beating the target of 50 days here. And then on our equity measures, so the percent of new physician hires coming from underrepresented minorities in medicine, you can see that they seem to be trending in the wrong direction. So for women, back in January of 2023, almost 20%. This year it's 10%. And you see similar decreases for Asian, Black or African American, Hispanic. There, we think some of this has to do with the decrease in unknowns, so getting better data, so kind of resetting our baseline, but also knowing that most years occur after the academic year. Most residents and fellows graduate in July, so the ends are a little bit smaller in these off quarters, mid-year, but it's a trend that we're going to be following carefully. Right, we should see some of the benefit of our Mosaic program, kind of initiatives that kind of fall under that umbrella and helping us here. And in this one, really proud of this. Hillary, who's seated next to me, deserves a lot of credit for this success here. This is our big push to have an equity lens incorporated into all of our performance improvement projects, especially the ones that come to our QAPI board meeting. The goal was to have 40, and for October through December 2023, almost doubled the goal at 85. And then even for partial quarter 3, 51 already collected. And as our QAPI meetings continue through this quarter, we'll see this number go up. But this is a good success, and we'll have to adjust this target as well. And then finally, we have retired the percent COVID occupied beds, therapies, and infusion treatments. But we wanted, because of our record census, to continue to show percent of occupied beds. So for quarter 2 of 76%, for quarter 3 of 78%. That might not look like the numbers that we expect that when we walk through our emergency departments and see a lot of admitted patients waiting for beds. We just want to remind people that this is an average across the system, but this is also including women's health beds, rehab beds,
pediatric beds
that you can't put med-surg, ICU patients into. So 78% is actually very, very full. Even if it doesn't show, like Jacoby, one quarter was 101%. But we have many of our sites, like Bellevue, that are over 90%, and that's incorporating all beds. Right?
Eric, but that raises the question going forward, should we change the metric?
Or break it down.
Because we could, well, for dashboard, right, we don't need, so, I mean, we already know that our pediatric beds and our labor, those are to me, the two sort of obvious, I would just do simple exclusions, right? They're dedicated areas. You can't put an adult there. You can't put a med surge person in a labor and delivery, and we're not having any occupancy issues in there. So to me, it's just irrelevant.
Okay.
Right, that the dashboard issue is what's the occupancy when you subtract out. ICU, I don't mind, right, because that sort of flows. But if you subtract out peds and labor and delivery, since they're not eligible for anyone other than that group, I think it would be a better metric.
We could do just adult, med surge and ICU beds.
Yeah.
Yeah.
As one.
We'll make
And where would you do you have a sense of what that would look like now?
Well, the med surge itself is running in most of the places
Like 100%,
95.
95, yeah.
I mean, it would run 100, except you have to clean beds.
Right.
Right. I mean, if
there's a
if
day,
it weren't for the turnover time, we always have the patient in the ED to
Yeah.
fill the bed. We
Right.
never, we really, I mean, even the occupancy is an understatement because you actually have the patient, they're just in the ED.
Right.
And you can't move them up because the bed isn't clean yet. So it's way too high. In most, there's still, as Eric said, there's still variation with some of our hospitals, like Met still runs a lower percentage. But, Jacobi, Kings, Elmhurst, Queens, who else is Bellevue, are just like, always, there's always a need for a med surge bed.
Yeah. I think that would be more effective than to have a narrowed metric.
Okay, we will update that for the next quarter.
Great.
And then this is just a visual, too small to read here, but you can see a lot of green, which is good. But we also like red and yellow because that means that we're pushing ourselves to improve. And so we will adjust our goals to put these back into the red and yellow so that we continue to strive to do better here. The one that we will retire is the enterprise data migration. And the proposal from Kim and the IT team working with Hillary is to actually do our initiative, which is both a sustainability and a financial project, which is to reduce printing, especially starting with color printing, right? It's a 2024, and we should be moving into more digital. I see Sally has iPad in front of her, so can we use our iPads and our phones and our computers more in presentations like this rather than printing them out and throwing them out after each meeting, and especially color. Right? It's really bad for the environment. It's expensive, the toner, and so Kim, collaborating with all disciplines here, is putting together a 5-year plan. So phase 1 is awareness, right? Did you know that we are printing out this much, killing this many trees, and spending this much on?
It turns out a huge expense for us has been the prior decision that every printed thing should have the color H&H
on it.
banner thing,
Yeah.
which has forced a bunch of things into color printers, right? And I mean,
Interesting.
maybe that makes sense when you're for marketing,
Yeah.
but I
But
don't think
internally.
we need internally to constantly see the color H&H border. But it turns out that that's been one of the big drivers of the number of color printers we have. We've eliminated that requirement that all H&H things be printed with that border.
Good.
Yeah, the things you don't think about. But we will bring a goal for that initiative that will be meaningful, that will have quarterly updates here.
Great. Yes.
I just-
Questions?
Yeah, I have 2 questions and a comment. Behavioral health seems to, I think I've heard and read that has embraced telemedicine. It's been used significantly, and at some point, and it may not be one of our metrics here, but it'd be useful to see how telemedicine is faring across the system. The use of telemedicine is faring across the system.
Sally, could you say more what you mean? Faring how, or faring in
How-
comparison to what?
How frequently it's used. For example, I think at H&H, seniors are adapting well to the use of telemedicine. We don't find that at Metro Plus. That hasn't been the case. And I'm just curious to know whether they're either tranches of people or tranches of illnesses that people are more likely to use telemedicine for.
I mean, part of the psychiatry is there's now a big body of research, in part because psychiatry never involved physical exam.
Right,
So in some way, they were the profession that could 100% say, we don't do physical exam, we don't need to touch you,
right,
therefore we're virtual, and there's a large, database showing that virtual care is as good. So a lot I don't mean us, but like
Right.
nationally.
right, right,
With the others, it's been harder because most people view it as plus minuses.
right.
Right, that there are certain advantages. Patient doesn't have to leave the house. Good for people who have steps, seniors, but no physical exam or harder to do a physical exam, right? And so not a lot of sort of research to tell you what's better. So at least in our system now, it's more of a necessity. So like we're doing virtual neurology at Queens in the evenings and weekends because we don't have a neurologist there. So clearly it's better, and the physical exam is done by the hospitalist, and then the neurologist consults on the virtual on the weekend. So we don't really, I think overall right now our stance has been you do it for necessity,
Right.
or you do it because the patient requests.
Right.
And some patients request, and for most providers are happy to do it, and we have the technology. But
But it's interesting, in
Sally's-
behavioral health, I'm sorry for
No, go ahead.
I guess you would have thought that the intimacy of the encounter would have required a physical encounter as opposed to on an iPad, and yet it seems to work.
the
Yeah,
research, and again, not just us, I mean, people have looked at this, or that there's a large group of people who are depressed, who actually have trouble getting out of the
door.
house,
Yeah.
and they benefit. A group of people who have paranoia, for whom the visit by the iPad seems safer to them. And so I'm sure there are people who would prefer to do it in person,
Right.
but at least there are clearly pluses on one side and not a lot of loss by physical exam.
Right.
But Sally, was your question that because, the metric, I mean, we're doing far better than our targets, does that have something to do with more?
That's, yeah,
virtual
like
visits.
using virtual express care, we get a list of people who are discharged, and the express care team is actually proactively outreaching them.
Right.
We are looking at piloting, starting with Bellevue kiosks in the emergency department, so that might be another opportunity if the kiosks aren't running at 100% occupancy, to have people who are discharged from the CPAP or the psych ER brought to the kiosk and immediately have it. And then also community health workers. That counts if upon discharge a community health worker meets with you and chats with you as they walk you to the door. That could actually count as the 30-day follow-up as well. But I think on top of everything that Mitch said, there also is potential stigma of being seen going into
Oh, that's a good one,
behavioral
yes.
clinic, right? Same with
More
abortion,
private.
right? And so privacy of your own home, it's just
Right.
you and the provider. Nobody knows that you're not going to run into somebody you know, or somebody sees you going into a behavioral health.
Right.
I had a sleep apnea exam virtually. I thought that was interesting. I wouldn't have thought.
Would you have said, as a consumer, would you have said that it would have been better in person, worse in person?
I thought it would have been.
But what
better,
about
but I
after
thought
having
it was fine.
experienced it?
Yeah, I thought it was fine for what was needed.
So I'd say the three big buckets are kind of replacing those primary care visits, specialty care visits with a virtual option, right, telemedicine. And then what Mitch touched on, which is how do we leverage video visits to make our specialists that are harder to recruit, where you don't need a full-time person in every hospital. How do we have the shared services and spread them across, right? Maybe you just need 3 neurologists covering one borough, not, right, one in each clinic and one in each hospital. And I'd say the third one, which we've also been very successful with, is the on-demand, right, which we power Metro Plus's telehealth benefit for the members, but it's urgent care, it's abortion services, it's substance abuse, it's behavioral health, all kind of on demand, and that's our virtual express care.
So interesting, because I'm just thinking about things that were either, you know, born or born more significantly during COVID, and things that we sort of gave birth to, many of which I'm sure I'm leaving out, but what stands in mind were the e-consults. I remember when we were just discussing it and how likely it was to work, and all of a sudden you're looking at 113,000 e-consult visits. Just amazing things that happened. I did have a question also about MyChart. We talked about people signing up, and then we talked about now getting some feedback on utilization. We've also had performance improvement projects where they discussed systems they developed to ensure that there were responses by the physicians or by whoever would be appropriate, and some different and clever ideas. I don't know if we're going to track those, or if we're using them as models, or how we're handling the what I call feedback.
Feedback, yeah. So the MyChart steering committee is actively tracking all those metrics. They have their own dashboard as well. At the beginning of this fiscal year, we looked at kind of the utilization metrics, and we also had conversations with Epic, with other systems, how they're tracking it, how they're using it. We didn't feel like there was one good utilization metric to replace the activation yet, but that was, right, we gave ourselves a year to work on that together with Epic. And so as we look at the metrics for next fiscal year, things to retire, things to add, we'll bring back a proposal on utilization metrics. But one of them is, are we responding within 48 hours, 72 hours of MyChart messages? But all the other utilization ones, we did not love entirely. It didn't feel like it was the right metric for us.
Sally, we're also working on, you'd like a translating MyChart messages that are sent in other languages, starting with Spanish.
Oh, wow.
So my patients frequently will message me in Spanish, which is fine, but then patients also message their non-Spanish speaking provider.
Right, right.
So a couple of the systems using Epic have created the ability to translate the text so that the provider can read it in English.
That's great.
Yeah.
That was it. Thank you.
Great.
Oh, I had just one last little thing. The unknown on the new doctors, at one point it was 24% and 16, now it's down to 7. Do we know how we made that happen?
Well, I think it was working with each of our affiliates. I don't know if Hillary wants to speak more to this, but they weren't. It was kind of like when we were looking at real SOGI data for us in Epic, right? Where it would be great to apply race, ethnicity, primary language spoken at home, and then we went to apply the filters, and I was like, oh wait, the data is missing on 40% of our patients, right? And so not meaningful to do it that way. So we actually had to take a step back and do quality improvement projects, working with our registration staff, expanding ethnicities from 20 to 200, right, to match the census.
Right.
And so that was quality improvement just to get the data to be able to apply the lens. Something similar is happening with each of our affiliates. They were leaving it blank. They weren't, right, collecting the data in the most, with the most integrity. And so working with them to say this is important, this is something that we're tracking now, we want the data to be better.
That's great.
Right, thank you. Other questions? I have a couple quick ones, but first, very happy to see all the positive trends, terrific work. I think challenge now is, do we have the right goals and targets? But sounds like you guys are working on that. Just on the stable trends, there's the percentage of uninsured patients enrolled in health insurance coverage. This is, I couldn't remember from prior, have we gotten close to the 90% target before? Is that is something that we're declining in, or is it, we haven't quite reached? It's page 16.
I think it's declined from like a historical high, but I think that in part, based on some of the things, both with recertification and also some of them talking about the closing of the age claims, we've seen the decrease like the last couple of quarters, so I imagine we'll tick back up. I don't think we ever got to 90% though, but
Okay,
we can confirm on that.
all right. So that is a few things that are, have created some challenges, but you're still hopeful.
Yeah, some staffing challenges as well that are temporary, but I think we can check what the high was and
Okay,
see also if it's worth revisiting the target, what's realistic.
right.
Probably so on the capacity side with the staffing, but also the demand side with the volumes that we're seeing across the board is making it more challenging.
Right, so I like the way the N is bigger. Yes, okay. And then just on the patient care revenues and expenses, and it's terrific. I know it's declined a tiny bit here, but it's still well above our target, which is great. I know that's always been the one metric we try to look at for the financial sustainability. And James, I remember during COVID, some of this was very, very high just because of the nature of our reimbursement and how that was working. Is this still a little bit of that overhang, or do we think this is a more stable level at this point, or?
We think this is more stable. I think there's potentially always a little bit of still, overhang, but, I think we've now seen enough quarters of performance and part of our efforts with our patient care revenue and with some of our, what were previously supplemental Medicaid that were sort of turning into rate adjustments.
Right.
That turns this into a patient care revenue piece as opposed to supplemental.
Yep.
And so we think that a lot of what we're seeing is real and sustainable. So I think we're planning to look at this target again.
Oh, great.
I could see it, having a little bit of noise, especially with such big numbers, but, bring this up and that this being more like the baseline we'd expect going forward.
Right, that's great. And sort of related to that is, and the one Sally should be happy is our Metro Plus spend going up, I think, is also very helpful. I mean, this is still hovering around our target, and I know some of that's related to timing, but is there something else going on that you're seeing this improving in terms of Metro Plus spend?
I think part of it is the timing. I mean, I think it was noted that we pay, the Metro Plus pays claims to us faster, so earlier on you might see our number a little bit higher, and then as you get into the later parts of the year, it dips a little bit, but I think there's always ongoing efforts, constant conversation with Metro Plus about.
I mean, the biggest effort and the one that certainly I'm most passionate about is the idea that top priority for new patient appointments should be Metro Plus Health and NYC Care.
Mm-hmm.
But if we, certainly we take, all insurers, but I sort of feel those people have other choices, and I'm happy to see them, but not at the cost of not seeing a Metro Plus Health or an NYC Care. So, I mean, Metro Plus Health do have other choices, but the power of having your own health plan is to be the plan and the provider so you can coordinate care. That's the power. Otherwise, it's just a plan. And obviously the NYC Care patients don't have other options.
So Mitch, is that kind of embedded in a scheduling process?
Yes,
Or?
yeah. I mean, it has been harder to achieve than you might think, in part because our providers are such good people that they have very hard time with the idea of being less available to someone. So, they don't, health and hospitals tradition is all comers. We see everybody. This is very hard. And of course, I want us to be that too. But what I mean is everybody, regardless of whether they can pay, regardless of their immigration status, I'm not as passionate about, the for-profit health plan, right, that wants us to see our patients, especially because they probably don't pay us very well. But it's so difficult for our providers to say no because
To
our
anyone.
provider, because they don't see patients in terms of insurance status and we don't really want them to.
Right.
So it hasn't been the easiest cultural thing to sort of allow people to, I mean, we constantly try to word it as a positive, not a negative. We are providing better access for the patients of Metro Plus Health and NYC Care. We're creating special appointments just for them.
Right.
That works culturally better than we're going to put patients of private for-profit insurers on a different waiting list. People are very uncomfortable with that. So it has not been as easy as you might think to get
And I think
people to switch.
internally, I think there can be an issue with people feeling patients should have choice. And
Patients should have
should-
choice. I want to see this patient. I see his mother, right? I mean, there are lots of reasons why it happens, right? If a patient, let's say a patient's a for-profit health plan, this certainly happened to me, and the person comes in and says, would you please see my mother? Right, we can say, no, I won't see your mother because she's a member of a health plan I don't like. You know, it's just,
Right.
I've also-
it's just hard to do.
I've also heard, right, I've been seeing this patient for 10 years, right? Are we punishing them for actually getting a job that gets them that Cadillac, insurance?
Right.
Am I gonna say now I won't be your PCP anymore, right?
Yeah.
And so we want to see people, right?
Right.
Get good jobs and get that Cadillac insurance. But yeah, I think it's this uncomfortable feeling with the without exception is our mission, right? And we obviously mean it the way that Mitch said it, but this without exception means we don't see people.
Okay. Well, on that note, any other questions for the
I guess
members?
I was also thinking about giving priority to Metro Plus in scheduling appointments to Metro Plus patients and to New York Cares, that internally, it can be a struggle between a sense that our patients should all have equal access that to appointments, that some shouldn't have earlier access to appointments because they're Metro Plus or they're
NYC Cares.
NYC Care.
Yeah.
Yes, that is what some people feel,
Yeah.
is that it should all be equal.
Equal.
Right.
But this is a case where equal is not equitable.
Yeah, correct. Yeah.
Okay. Well, any old business? Any new business? There being no further discussion, meeting
Oh, you
adjourned.
have-
Right on time.
Oh.
No, I was just going to do a time.
Thank you.
Great.
This meeting is no longer being recorded.